A very good evening to all of you. So now we will discuss about tonsillitis, that is the infection of the tonsillar tissue. See, tonsillitis of acute nature or chronic nature. So the most common organism responsible for the tonsillitis is hemolytic streptococcus. So hemolytic streptococcus is most common organism responsible for the tonsillitis. Try to remember in the ear infection or ASOM or CSOM, the most common bacteria involved is Streptococcus pneumoniae, whereas in tonsillitis it is hemolytic streptococcus. So mainly tonsillitis occurred in the school-going children, or we can say children aged between like 3 to 15 years, somewhat like that. It can also affect to adults also, but rare in infants or age group of above than 50 years. So what will be the symptoms of the tonsillitis? Firstly, there will be throat pain, painful swallowing, some sort of foreign body sensation in the throat, and there may be referred pain in the ear. And what else? The fever if the septicemia occurs to the patient. So child may have fever or somewhere dull appearance. So look at this diagram. It is showing this tonsillitis. You can see this is my tonsillar tissue with the lots of whitish dots like there, which is suggesting of the folliculitis. Okay, so this whenever there is a tonsillitis, so what happens is throat redness will be there with the hyperemia or the congestion of the anterior pillar or the uvula or the part of the soft palate. So throat redness will be there with the hyperemia of the soft palate, uvula or the anterior pillar. And sometimes this jugular-digastric node, which is the main lymphatic drainage of the tonsillar tissue, may be enlarged. So we can palpate this jugular-digastric nodes in the baby or the children affected with the tonsillitis. So what are the type of the tonsillitis? The first is acute superficial tonsillitis, where the superficial layer of the tonsillar tissue is severely inflamed. So you can see in this diagram this complete red uvula, red anterior pillar, congested tonsils. So this is a picture of the acute superficial tonsillitis. Then comes the acute parenchymal tonsillitis. What do you mean by parenchyma? That means a complete tissue of the tonsil. So in acute parenchymal tonsillitis, as you can see in the diagram, this tonsillar tissue is enlarged and inflamed or swollen. The third type is acute follicular tonsillitis. We know about that tonsillar tissue is having crypts. So what happens, the pus or the bacteria invasion and the collection of the pus point, or we can say the degraded material, will be in this follicle, leading to appearance known as acute follicular tonsillitis. As you can see, the whitish, all the follicles are filled with this mucopus. So this is acute follicular tonsillitis. Then last one is the acute membranous tonsillitis, where is a whitish, dirty white or curdy white membrane will be present over the tonsils with the inflammation of the tonsillar tissue. We all know that membranous tonsillitis may happen in firstly in diphtheria. Then comes the candidiasis. Candidiasis typically gives the dirty white appearance. Then there are other diseases also like the infectious mononucleosis. We will discuss in this slide. Now, what is the treatment? The first treatment will about for the child is firstly give the analgesic. Advise the baby to go for the little bit of rest, that is a bed rest, then plenty of the fluids, and give the antibiotics, analgesics, and we can suggest the patient to do the gargles with the betadine, and there are other sorts available in the market. What can be the complication of acute tonsillitis? Firstly is the chronic tonsillitis, that means the repeated or chronic infection of the tonsillar tissue. Then what else? There may be the paratonsillar abscess, that is the abscess in the tonsillar bed, or we can say space beneath the tonsillar tissue. Then there may happen the parapharyngeal abscess, cervical abscess because of the involvement of this jugular-digastric nodes. If this jugular-digastric node become prominent, sometimes the abscess occur there presenting as a neck abscess. And there will be referred pain, and sometimes because of the tonsillar infection may ascend through the eustachian tube into the ear, so leading to the acute otitis media. Then what are the other complications like rheumatic fever, acute glomerulonephritis, or subacute bacterial endocarditis? Now let's talk about chronic tonsillitis. That means the chronic infection of the tonsillar tissue, maybe because of infection from the teeth, maybe because of infection from the nose or the pharynx or the larynx or some other way. But if tonsils is continuous continuously or repeatedly infected, it is known as chronic tonsillitis. So what will be the clinical feature? There will be repeated attack of sore throat. Second, there will be throat irritation and the retching sensation in the throat leading to coughing, leading to some foreign body sensation in the throat. Taste will be altered. There will be bad taste in the mouth, and sometimes tonsils are so enlarged they will cause difficulty in speech or difficulty in swallowing, because whenever patient is trying to swallow the food, so it will touch around the tonsillar tissue, causing the pain or some sort of discomfort to the child or the affected patient. What are the types of the chronic tonsillitis? Firstly is the chronic follicular tonsillitis or chronic parenchymatous tonsillitis. We have seen in the diagram in the previous slides how the follicular tonsillitis or the parenchymatous tonsillitis will look like. Okay, now what will happen whenever there is chronic tonsillitis? So these tonsils will have some yellow pus discharge or whitish, dirty whitish collection of the material in their follicles or over the superficial layer of the tonsils, and there may be the enlarged jugular-digastric nodes, and sometimes if we apply the pressure over the tonsillar tissue, some cheesy white material and some sort of pus will come out. This sign is known as Irwin-Murray sign. Sometimes there is tonsillolith, because the food will get accumulated in these crypts. So when our patient will come with a complaint of like some whitish discharges there from the tonsillar tissue, and patient what he do? He himself try to press that tonsillar tissue. So this is somewhat known as Irwin-Murray sign. And there will be fusion of anterior pillar if tonsils are inflamed. You can differentiate where the anterior pillar and where is the capsule of the tonsil. Now, what is the differential diagnosis over the membrane of the tonsil? We have already discussed. First one is a membranous tonsillitis, then comes the diphtheria. So we are already giving the vaccination for the diphtheria, but still some patients, some babies may have diphtheria presenting with the dirty white membrane over the tonsillitis, over the tonsillar tissue. And what is the typical of diphtheria? Whenever we try to rub that membrane, so it will bleed. Whereas in candidiasis, suppose the patient is having candidiasis, so there will be layer over the tonsils, but if you try to rub that layer, so the whitish layer will get separated without any bleeding. And then comes the Vincent angina, where there is a black colored patch over the tonsillar tissue. And what are the other diseases like infectious mononucleosis, agranulocytosis, leukemia, some sort of aphthous ulcer sometimes, because in aphthous ulcer we know whitish structure or dots like structure are present. And then come malignancy of the tonsils also, and then maybe trauma or candidal infection we have already discussed. Now, what are the indication of the tonsillectomy? Again, this is important for the examination point of view. The absolute indication where we have to do the surgery, the first one is peritonsillar abscess. If there is an abscess around the tonsillar tissue or in the tonsillar bed, so firstly we will prescribe the antibiotic to subside or reduce the inflammation of the abscess. Then after 4 to 6 weeks of that peritonsillar abscess or quinsy, we will advise the patient for tonsillectomy. So it is an absolute absolute indication for the tonsillectomy. Then recurrent infection of the throat, or we can say over the tonsils. If patient is having like episodes, 7 episodes or more than that in a year, or consecutively 2 years, patient is having more than 5 episodes, okay, or suppose 3 episodes per year for consecutive 3 years. If patient is having so many of episodes, so according to World Health Organization guidelines, so we should advise the patient for the tonsillectomy, and it is considered absolute indication. Then what are the other absolute indication? Suppose because of the tonsillitis, patient or the baby is having febrile scissors, so then we have to do the tonsillectomy. Then come if tonsils are so much of enlarged that they are causing the difficulty or painful swallowing. If the speech is altered, patient can't breathe properly or can't talk properly because of the enlarged tonsils, then also it's an absolute indication for the tonsillectomy. And suppose if we doubt there is some malignancy in the tonsils, so again we have to do the tonsillectomy. Generally in the tonsillectomy, tonsils malignancy, patient will present with unilateral or one-sided enlargement of tonsil. So if any adult present with unilateral enlargement of the tonsil, we should think of malignancy. What are the relative indications? Firstly, the diphtheria carriers who are not responding to the antibiotics. Then comes a streptococcal infection carrier, and then comes a chronic tonsillitis, altering the taste of the patient or the bad taste or some foul smell in the mouth, and then repeated infection in the tonsils. And as a part of the another operation also, we can do the tonsillectomy, like if we do the styloid process, enlarged styloid removal. So we can go through the internal approach. What we'll do, we will remove the tonsils, explore the tonsillar bed, and we will locate the styloid process and remove it. And what are the other surgeries like palatopharyngoplasty used done in the sleep apnea surgery. So in that, and again the glossopharyngeal neurectomy. Suppose patient is having pain, continuous pain in the area supplied by the glossopharyngeal nerve. So to do the neurectomy, we have to explore firstly the tonsil and then reach till the level of the glossopharyngeal nerve and do the neurectomy. And what are the contraindication of the tonsillectomy? The first contraindication is the polio. It has been asked multiple times in the exam. Why polio? Because we all know the glossopharyngeal nerve lies in the bed of the tonsil. If we remove the tonsil, so it will come in direct exposure. Whatever we are eating or any sort of pathogens we are inhaling or ingesting directly can affect the glossopharyngeal nerve. So firstly the polio. Next one is acute infection, because if we do the surgery in the acute infection, it will be lots of bleeding and some sort of tragedy will happen while doing the surgery. Then again other contraindication is submucous cleft palate. See, baby is already having cleft palate, that means it is already having the problem of regurgitation, that is nasal regurgitation. Patient will complain of the whatever he or she is eating will comes into the nose. So again, if you remove the tonsils, again this area will broaden up, the open palate area will be broadened up, so it will further lead to more complication. So this is an absolute contraindication. The cleft palate submucous is an absolute contraindication for tonsillectomy. Then babies age less than 3 years, you shouldn't go for the tonsillectomy. And suppose patient is having some UTI or some other septicemia or some other infection in the body, then again we have to wait and don't do tonsillectomy at the same time. What is the position of the tonsillectomy? That is a rose position. How it happens? In rose position, what we do, we just lie down the patient in the supine position. I'll put a shoulder bag beneath the shoulders so that neck will be extended. So that is known as a rose position. And what are the methods of the tonsillectomy? Cold methods are like we can do by the knife and gradually dissect it, or we can use the harmonic scalpel or cryotherapy. Hot methods are like the cautery, laser or coblation. Cobblator is there. Lots of facilities are nowadays available in the hospitals. So new advances are there. So we can do tonsillectomy by means of cobblator or laser. What are the complications? The first complication is the bleeding. While doing the surgery, if the bleeding occurs, that is known as the primary hemorrhage. So if any injury to vessel, there will be bleeding. So what we have to do, we have to ligate that vessel. And there is reactionary hemorrhage also. In reactionary hemorrhage, generally bleeding occurs within 24 hours, like within 1 day. Why this occurs? Mostly because of slippage of the ligature. Suppose we have ligated the vessel and in the meantime after 3 to 4 hours there is a slippage of the ligature, again leading to the bleeding, that is known as reactionary bleeding. Then comes a secondary hemorrhage or secondary bleeding. It usually happens because of the infection in the tonsillar tissue, again on some sort of trauma, again after 3 to 4 days or 4 to 5 days suppose. So what we do, if it's because of the infection, what we'll do, we will give the IV antibiotics. Now what is the vein that is most commonly injured? That is the peritonsillar vein. We try to remember beneath the capsule there was a vein which is running. So that is a paratonsillar vein or peritonsillar vein. So that is the most common vein which is being injured while doing the surgery. And the arterial bleeding is there. That is mainly because of the facial artery branch, that is the tonsillar branch. Now there is one sign, Grizzle sign. So it has been asked in the exam, what is a Grizzle sign? While doing the surgery, we put the patient in the rose position. So what we do, we extend the neck. So sometime post-surgery patient will complain of the pain in the neck because of overextension of the neck, which will lead to some pain at the C1 or C2 level. So this is known as Grizzle sign. So I hope you got it. Thank you.